Most students get weakness questions wrong, not because they don't know enough diagnoses, it's because they miss this pattern. Chronic, symmetric, proximal weakness, you want to think muscle, not nerve. That one pattern localizes the problem immediately. The reason students miss this is they don't localize early. Weakness isn't a list problem, it's a localization problem. High performers don't memorize long differentials, they identify patterns first. Start with safety, then localize, then use pattern and time course to refine. This is how you go from a broad differential to a focused diagnosis. I'll show you the key pattern that narrows your differential quickly and the one decision point most students miss. So let's apply this to a real patient. We have a 52-year-old female who presents with weakness. Before even walking into the room, we should already be thinking, what's my broad differential? What questions actually matter? What exam do I need to perform? This is how you move from memorization to clinical reasoning. So first, we build a broad differential. Weakness has a large differential list, but most causes fall into a few major categories. Central neurological causes, like stroke or cord compression, peripheral nerve causes, like neuropathy or Guillain-Barré, neuromuscular junction disorders, like myasthenia gravis, muscle causes, like inflammatory or medication-induced myopathy, and systemic causes, like electrolyte abnormalities or anemia. At this stage, we're really not trying to be right, we're trying to be complete. But this list alone doesn't help you. What matters is how you narrow it. Now, this is where the diagnosis actually starts to narrow. Instead of ordering labs, we start with the history. First, clarify what the patient means by weakness. Is it true weakness or fatigue? Is it difficulty generating force or just low energy? These are completely different pathways. Next, we'll look at time course. Sudden onset in minutes to hours, think vascular or metabolic. Subacute, so days to weeks, think infection or inflammation. If it's chronic, like months to years, think nerve or muscle. But here's the key step, pattern recognition. This is where most students miss the diagnosis. Focal weakness, you want to think central nervous system. Proximal weakness, you're thinking hips and shoulders, so muscles. Distal weakness involves hands and feet, so you want to think peripheral nerve. Symmetric patterns, start thinking systemic. Asymmetric patterns, think more neurologic. And then look for key clues. So fluctuating weakness, probably thinking neuromuscular junction issue. If there's ascending weakness, think Guillain-Barré. If it's proximal weakness, think myopathy. And of course, always screen for red flags. Are there any sudden focal deficits, bulbar symptoms, respiratory weakness, altered consciousness? In an OSCE, this is where you would say, I'm screening for life-threatening causes of weakness, including stroke, spinal cord pathology, and respiratory compromise. Now, let's put this all together. Weakness feels overwhelming, but most cases are narrowed quickly if you follow a structure. So I created this algorithm to help with that. First, you want to check if there's any red flags. If there are, then this is an urgent evaluation and you refer to the ED. If not, you can move forward. So we'd start with the time course. Is it acute, in minutes to hours? Then we could be thinking of a stroke or metabolic cause. If it's subacute, so more like days and weeks, infection or inflammation is more likely. And then if it's lasting months to years, that's more of a chronic time period. So maybe something like myopathy or neuropathy. Next, we want to look at patterns. So if it's symmetric and ascending, think Guillain-Barré. If it's proximal weakness, think myopathy. If it's a distal weakness, neuropathy is more likely. And if it's fatigable, we'll be thinking about the neuromuscular junction. And then the last step is to localize it. So is it happening in the brain, spinal cord, peripheral nervous system, at the neuromuscular junction, or in the muscle? So here's your key shift, pattern recognition. This is what actually localizes the problem. Once you can localize it, you move from a really broad differential to a short, focused differential list. And that's the difference between memorizing and thinking like a clinician. Okay, now let's go back to our patient. We have a 52-year-old female who presents with progressive weakness over 3 months. She reports difficulty climbing stairs and rising from a chair. She also notes trouble lifting objects overhead. There's no sensory changes, she denies pain, and there's no recent illness. She is taking a statin that she started about 6 months ago. Now that we've asked focused questions, our exams can be targeted, not random. We're not trying to examine everything, we're confirming our differentials. Don't forget to check vitals and make general observations like alert and oriented ×3. I've created a table here of some targeted exams we might want to perform for this case in our differential list. So for myopathy, you might want to perform proximal strength testing. And let's say for our patient today, we see weak hip and shoulders. If we're suspecting more of a neurologic central cause, we'd want to check for cranial nerves, do some deep tendon reflexes. And then for today's patient, let's say there's no focal deficits. If we have peripheral neuropathy, we'd want to add a sensory exam to our neuro test. And for this patient, let's say that sensation is intact. If there was a neuromuscular issue, we'd want to test muscle strength, so be sure to hold for 5 seconds to really test fatigability. And then we also want to test fatigability. Let's say for this patient, there is no fatigability. And then lastly, if there was a systemic cause, that's where our vitals and general observations can also be powerful. And for our patient today, let's assume there's no signs of infection. And don't forget, if you're suspecting a stroke, that be fast mnemonic can be really helpful to rule out any symptoms. So balance, eyes, face, arms, speech, and timing. Be fast. Now that we've performed targeted physical exams, let's refine our differential list. We're not adding any diagnosis at this point, we're prioritizing. So this patient has chronic, symmetric, proximal weakness. That pattern really stands out to me as localizing to the muscle. So now my top diagnoses are statin-induced myopathy and inflammatory myopathy. Other causes like neurologic or neuropathic have become much less likely with this case, but to avoid premature closure, it's good to have a few top differentials still. Okay, so let's bring it all together and present an assessment. We have a 52-year-old female who presents with progressive muscle weakness over 3 months. Exams today show symmetric proximal weakness without sensory deficit or fatigability. This pattern is most consistent with a myopic process. Given statin use, statin-induced myopathy is most likely here. Inflammatory myopathy remains a consideration, but for next steps we should include a CK level and medication review. Now, let's talk about where students go wrong. First, failing to localize. If you don't identify where the problem is, your differential stays too broad. Second is ignoring the pattern of weakness. If you don't distinguish proximal versus distal, or symmetric versus focal, you'll miss the diagnosis. And third, ignoring time course. Not all weakness is acute. If you miss chronic patterns, you miss muscle and nerve causes. And remember, labs don't fix poor clinical reasoning. If you take one thing away from this video, I hope that its weakness is not about memorizing a long list of diagnoses. It's about asking the right question first. Where is the lesion? Then use pattern and time course to narrow your differential. So in this case, chronic, proximal, and symmetric weakness, be sure to think muscle. If you want to get faster at clinical reasoning and not just for weakness, but any chief complaint, I break down the same framework across the entire ScrubNotes Chief Complaint Series. So if this clicked for you, check out the rest of the videos.